and welcome Dr. David Pomeroy. He's the host of the ADHD Focus podcast, the founder of the ADD Center in Bellevue, and also targetingadhd.com. Did I get that right, Dr. Pomeroy?
Yep.
Okay. And he specializes in the diagnosis and treatment of ADHD, board certified in family medicine, a fellow in the American Academy of Family Physicians, doing amazing work as an advocate, speaker, and writer. And we're going to have an interview type conversation, kind of a fireside type chat. Dr. Pomeroy and I have talked over just kind of some questions and topics and the myths that are not just out in general society, but in the providers' offices too. So I'm going to turn it over to you for a minute, David.
Okay. I'd say that, one of the questions that Beth passed on to me that people had sent in to her was something about how do you help, where the biases and things come from that doctors hold. Well, they have the same prejudices, biases that get introduced to them all the way up until they're in medical school, and they get another whole set from professors or trainers in residencies. I've seen notes that patients give me that pass notes from doctors they've been with, and psychiatrist says, well, this kid can have ADHD. He spent the last hour with that thingamajig in his hands while his mom and I were talking. Yeah, he was playing a video game or a game on the Game Boy or something. Of course, his attention wasn't jumping all over the place. And the docs who, like Beth's doctor, adults can't have it, or you graduated from college, you can't have ADD, crazy stuff. And those, I think, stem from the fact that there isn't specifically training unless you look for it. So just in the general things in medical school, it may not even get mentioned, or the people who mention it are the ones who are ill-informed because they're thinking of the 1990s when hyperactive 8-year-old boys were the only ones who had ADHD. So getting the knowledge to filter out to other physicians is really, really tough. There's all this hoopla about, we need guidelines for diagnosis, and we're finally getting some in the US. The DSM-5, DSM is the Diagnostic Statistical Manual of Psychiatric Disorders or Mental Health Disorders. That's the Bible, if you will, of the diagnosis codes and criteria for a diagnosis and how it's different than others. That's been out since 2013. I doubt there are very many doctors that have a copy of that on their desk or within, or even as a file and something on their computer. But that's where the criteria are right there, the explanation of how it can be with other things, how you can sort it out from other things, but docs don't read that. I don't think I looked at it until I started doing this. That was after 26 years, general family medicine, and I was seeing people with anxiety and depression and all these different things. So the answer with a lot of docs not knowing about it, if you don't look for something, you're not going to find it. Yeah. And they don't even know to look for it because they don't have, I guess, the knowledge and perspective that, gee, this person's anxious about all these different things. And if they would let that person talk a little bit and find out, so I can't get this done and I can't get that done, and I've got so many different things on my plate and I can't sort them all out. That's ADD. That's anxiety of not getting things done. That's not a primary generalized anxiety disorder. So treating that kind of anxiety with, pick your favorite SSRI, sertraline, or escitalopram, any of those, isn't going to work for that person's anxiety, is going to give them side effects, and they're going to get more frustrated and maybe see another doctor or try another different medication. And it just rolls along. People,
Till they try a new
somebody
one. They
in
keep
their,
trying, yeah.
yeah, their family or a friend says, boy, it sounds, maybe that's ADD you're dealing with. Well, how can I find that out? My doctor says they don't believe in it. And I say there's only one thing to say when your doctor says they don't believe in it. Goodbye. You have to find someone else.
And it's so hard for us to find doctors,
Yes,
right? I
it
mean,
is. And,
yeah, I mean, it's,
and I'd say around here, certainly in the Seattle area and in Washington, there are many more psychiatric nurse practitioners who definitely know a whole lot about ADD than there are doctors who do, because the University of Washington has an excellent psychiatric nurse practitioner program.
ah,
So someone has to be a nurse practitioner for a while before they can do the psychiatric nurse one. I think unless they've been a psychiatric nurse, like in a hospital. And then it's, I believe, a 2-year program, and they're doing different clinical rotations. So they have a huge repertoire of knowledge, more than most doctors do, except probably psychiatrists. And that includes ADHD. So, and nurse practitioners in the state of Washington can be independent in practice. They don't have to be with a doctor's practice. So
yeah.
there's a group of, I think they're now 6 family or psychiatric nurse practitioners in Linwood. There's a group of about 7 here in Bellevue. There are some up in Snohomish. I don't know their names. I don't think they're in a group. So there are a number of different people, but you have to look at psychiatric nurse practitioner. They may not be in the directory of ADD or CHADD, which is another place to look.
Yeah.
So that's one of the kinds of things that I guess you have to be within the ADD provider network, unofficial network, to know of how the psych nurse practitioners. So that's one place to look if you can't find MD or DO who knows what they're talking about with ADD.
So, I have a long list of questions that people have passed in, but I think
Mhm.
maybe, we might just, we could take just questions. If people have come across myths and you want to do that, go ahead and put them in the chat. Before we get to that, how did you decide to move or transition from general family practice
Mhm.
into specializing in ADHD, and how has it changed over that
Okay,
time?
how has it changed to take a couple hours? But my move was a combination of things. It was in 2001 that a therapist I was working with said, you may want to look into having about your ADD. And I said, what? So I went and saw the psychiatrist he recommended, someone who was very experienced, and she talked with me for an hour and a half. And she said, yeah, I think you have inattentive ADHD. And I said, the first question I had was, how does someone get through medical school with ADHD?
Yeah.
And she said, because that's your hyper focus.
Mm.
And she was exactly right. I was a solid B student in high school and college. I had honors all the way through med school because I love medicine, everything about it, and I can just dive into it. I don't like the direction the practice of medicine has taken, but I like practicing medicine. So there's my diagnosis. So then I had some more, I guess, interest when, and I can remember one mom talking with me. She had her probably 11-year-old son. This was in November. She said, he has an appointment with a psychiatrist in May. I know from everything I've read and the fact that 4 people in my family have ADD, I'm sure that's what he has. Is there something we can do before waiting till he flunks another year in school? And I thought, well, I could learn something about it. And so that's where I started reading and got more and more interested. One new medication had just come out, and one other, until I was around, got around, Dr. Ted Mandelkorn on Mercer Island was about the only other doc doing only ADHD. He was a speaker at the dinner meetings that the companies put on that doctors go to learn about medications. And he and I got talking. He said, we need more people doing this. Then the sign went up, and what led to partly my diagnosis, I'd been a practicing physician and was asked to head up one of the neighborhood clinics in the UW system to help start it. I'm not an administrator.
You have ADHD.
Gee, ADHD, planning meetings, organizing things, communicating with people, remembering details. Nope, not my thing. And the way those were structured was a physician was the chief administrator of the office as well as practicing medicine. So it's already too much for one person to do. And I just was behind on everything. I'd walk in to a weekly meeting and think, oh yeah, a meeting. I should have sent out an agenda. I wonder what we're going to talk about.
Yeah.
And certainly not planning ahead enough. So that wasn't working. And then a sign went up in the waiting room. If you have a second problem, make a second appointment. I said, nope. I've never practiced medicine that way. I never will. I'm out of here.
Yeah.
So that was meanwhile, there are all these other factors going on, and Ted saying, you can do this. So I did. So I could practice
Well,
medicine the way I thought it ought to be.
a
So
lot of
that's
people
how
are
I
very grateful.
ended up done.
I want to turn over to some questions. So Eric, let's go with your question. Go ahead and ask it, or unless you want me to ask it for you.
Oh, okay, Beth. It's not going nicely, everybody. Um, I know one of the myths. Until you really dig into the research, Dr. Pomeroy, and medication isn't my thing. I'm more go the route of behavioral therapy as a kind of a first kind of plan of attack.
Mhm.
But
Mhm.
medication, I'm a former instructor with the CHADD parent-to-parent program, and it's a component of the multimodal aspect of it. But the
Mhm.
people go into it, and in the general press and magazines and news, well, it just never goes away. They say Ritalin and all these drugs are dangerous and
Yeah.
addictive and overprescribed. And then you've got to dig, and I end up
Yeah.
I end
If
up trying to look for research to disprove people all the time. I don't know how you deal with the overprescribed and dangerous
that's
medication.
that's partly why I have the podcast. Why
Okay,
I see a comment about that in one or another article thing, I'll write back and say, no, it's not overprescribed. There's, of course, that's a myth that's held by the people at the DEA for sure, and even the FDA. Oh, diagnosis is people are overdiagnosing it, overprescribing it. Something I saw recently looking at the increase in diagnosis, particularly around COVID and afterwards, and people in this country are saying, oh, there's everybody worldwide, 3 to 5 to 6% increase in diagnosis of ADD. It's not just in the US, it's everywhere. And so many, I think so many people in the DEA, FDA, individual docs, and certainly the people who write for the Wall Street Journal, the New York Times, and a lot of popular media think it's just in the US. Well, it's about, 5 or 6% in Brazil, Denmark, Canada, Taiwan, the UK. It's a human condition. It's not just because of video games or one thing or another. And I think there's a scare, which I understand, but again, Eric, as you said, people don't dig into it, about Ritalin, and that's make people zombies, or Adderall, that's so addicting. Yes, before the year 2000, Adderall itself is even a tablet drug, I think came out in the 1990s, but anything amphetamine, plain dextroamphetamine, Adderall, that was a no-no because there were people misusing it recreationally. So Ritalin was the only thing docs knew of to prescribe for it. Well, a lot of people with ADD do very well with Adderall or Vyvanse or an amphetamine. They have side effects, or they just don't feel good on Ritalin. The other thing is, most people thought to have ADD back in the 1990s were hyperactive boys mainly. Okay. Oh, they're finally sitting still and behaving, says the teacher. And mom says, yeah, and he's coming home and he's just kind of there, because they were over medicated so they wouldn't be hyperactive. So there was a lot of misunderstanding about how it worked. Then, oh, amphetamines, they're terrible. You're going to get addicted to them. I am absolutely convinced that someone who truly has ADHD, they take their medication as prescribed, that is, as a capsule or a pill, and not crunching it up and snorting it or whatever, cannot get addicted to an amphetamine.
If they can remember it.
Yeah, if they can remember to take. I mean, how many heroin addicts forget their fix of the day? But because we take enough and it works well, you take more than that, it doesn't feel better. You feel worse. There's no euphoria. You don't get high. And I can understand that people without ADD take it, and yeah, they feel great. Man, this is super. But then that effect wears off, usually within 3 to 4 weeks. Oh, but if I take 2 of them, I can get back to that. They're chasing that rush, that feeling super energized. And
my counterpoint, Dr. Pomeroy, when this myth pops up again and again, I go to the CHADD collection of fact sheets as running my chapter, and you may know of them or may use them or may not, but there's about 20 different fact sheets that summarizes CDC findings and research studies. I don't know if you take those steps in your podcast and throw a reference in as a clinching point or any kind of a go-to restudy to like nail the case down. And the documentation is, I like offering people the fact sheet on whatever it is, including medication or any of the rest of them.
And more often I'm asking anyone who questions it, okay, if there were information, factual information, research backed, experience backed, which would give you good information about ADHD, would you want to know it? And some people are going to say, no, I already know about it. Okay, it's not worth spending your time dealing with them because they
Right.
aren't gonna listen.
Yeah.
But some people would say, yeah, okay. And then you point them to the fact sheet with CHADD. One resource I love for both patients, but also for professionals is the organization called CADRA, which is the Canadian
Yeah.
ADD Resource Alliance. That they've been going 20 years, started as a group of psychiatrists and psychologists in Canada who thought we need to educate other therapists, physicians, clinicians, school nurses, everybody about ADD, as well as have information for people who may have it or wonder about it. And they've got an excellent website. There are like 4-week courses on your own speed that they have for docs about diagnosis or about medications or treatments. They have forums. They have the best annual conference I've been to about anything. So there's good information there. Also, their website's easy to get around and see things. So that's a
Just put
resource.
their link in the chat for anybody that wants it. I also put the family physicians article
Oh, thank
in the
you.
chat as well for people, so they can
Great.
do that.
Thanks. So I think referring a person, not a clinician or a clinician, here's some resources that are reliable, not hearsay, based on research. You can contact people in there if you have questions. And so that's evidence-based. I despair of trying to convince anybody who writes articles from the New York Times or Wall Street Journal who always has a
Right.
negative thing to say. And a lot of professionals do too. And that's where there was one headline, oh, Adderall is twice as likely to cause heart problems as methylphenidate ones. Dig into it. Yes, the rate was 4 out of 1,000 instead of 2 out of 1,000. You're right, it's twice as much. That's the relative risk. Let's look at the absolute risk. And that's an example. The 2 and 4 out of 1,000 isn't the actual number. That's just what occurs to me. So it's the details that people don't look into. It's the headline that makes the difference.
Well, thank you very much. Thanks.
Frustrating. Yeah,
And
thank you, Eric. Okay, Lauren, you're next.
Excuse me.
Sorry, I
I'm
should have
getting
given
over
you a warning.
No, I'm getting over a head cold. I'm gonna sound like this the entire night. I apologize if this is not an appropriate question and simply say so. I don't want to hijack the conversation. I'm curious if you
Mhm.
see a bias against mental health treatment in general in non-psychiatric medical providers. That there is no such thing, or they downplay or
I think that's less. I guess it was a collective stigma. I don't think that's there as much. I know some parents will say, well, I don't want my child to be labeled or stigmatized in school. Okay, you don't want him to be labeled as having ADD. He can be labeled as a druggie or a high school dropout or that kid who has the sign saying don't drink and drive, whatever, because they get killed in a car accident. You can have that label. You can have the label that have ADHD. And yet that also takes understanding that it's an unfortunate name. It's not a deficit, it's a difference. Attention difference disorder would be a much better name for it because there isn't a deficit. We can pay attention great. it's just on what we're interested in and not necessarily what's in school or whatever. But I think that the whole stigma of you have a mental health problem is less. When people, yes, acceptable to have a medical leave because your anxiety's sky high and that's interfering with the way you function. So I don't see that so much as a more specific things as far as ADD. You couldn't have it because you graduated from college or other silly things.
Yeah. Okay, Sally.
Hi. Yeah, well, this is an interesting situation. I wanted to know if you work with people who are seniors or,
Mhm.
so it's kind of what, I mean, I'm diagnosed. I'm just trying to put together stuff that's, I'm trying and wasting all these years trying to figure out what to do.
Yeah.
And I have
Well-
comments on you on what I think needs to happen. Actually, this is kind of an ADHD little bops here and there instead of a real plan. So anyway, I don't know if
Yeah,
that's,
my oldest patient is, I think she's 81 or 82 now. And she takes the upper limit of dosage of Vyvanse, 70 milligrams.
he does, that's what I take. Well, I went to
she-
60, now I'd want to go back to 70. My prescriber doesn't.
Yeah, and I've seen people say, oh, you're over 65. I don't want to give you heart problems. You know what?
We don't even want you to be on it. You're old and we don't have we don't have any
Yes.
proof. And it's
Right.
not even, it's just white boys, it was not
Yeah.
even different.
Or it's,
people,
yeah,
young
you don't have a job, you don't need to worry about it. Okay, but you drive a
I'm-
car and you have to pay bills and you have to
But
get.
we haven't educated people, so we have to change it around. So I don't know.
Exactly.
I don't know if it's possible. I'd like to sit down and actually, just tell you what I think might be helpful. If you're trying to change this and address some of this at your level, I'm a person
Yeah.
trying to put my life together and get back to work.
Yeah,
But
that's why I do the podcast, because I can reach a lot more people, or
Yeah.
I do things like this. Because, yeah, one-on-one, but people I see in my office, they already think they may have it. Now, sometimes,
for me, I know that's not
yeah,
what I'm
sure.
trying to, but I also am very frustrated hearing just this,
Mhm.
because we are not going forward in the way we need to be going forward.
Oh, absolutely.
And I told
Absolutely.
Beth, my cousin is in Arkansas and he's a judge. And he said, I think I've seen a lot of ADHD kids come through here and, and
It
I
has.
sent him Dr. Dodson's stuff and he said, if I'd known some of this, I'd like to know more, but I could have understood
Yes.
how
Oh,
to
exactly.
help them
Exactly.
improve rather than punish them.
Yep. And so he's willing to listen.
Yeah, but
And
he's
a lot
just
of people
retired,
aren't.
but
The
the thing
problem
is,
is, if someone isn't willing to listen, you can't convince them. It's
yeah, but it's kind of, we're just little bops here and there instead of a unified effort. So one of the things, I'm also dyslexic, and I caught in touch, I reached out to somebody here who immediately sent me off to Scotland. And I'm like, what the hell? And what's intriguing here is because they have socialized medicine, and this is, I think, important.
is with Canada too.
Yeah, they invest because it costs them money when they see that people with ADHD, they see with people with dyslexia are in trouble. And what they were able to prove is that 40% of the prison population in Great Britain are people with dyslexia. We are not doing that. We need to do
Well,
that. We need real facts. We're saying,
we-
look at the
we know
data.
that-
We're not
We know
producing-
that 70% of people in jails, or at least some studies that have looked at that, 70% of inmates have ADD.
I'm not
That's
surprised.
the statistic, but getting some help for them in jail or to prevent them to get there, that's
It's
takes
the
a
whole
lot of
thing.
different things. It's
Well,
important and it's
yeah.
terrible that it
But I-
happens.
So I'm going to come back to, just because I don't want to take all this up. I'm now really wanting to find another prescriber. The one I have, because it's Medicare, they're paid very little, I think, but it's, I'm always, it can take a week to get her to turn around, with the shortages on Vyvanse,
Yeah.
and before that was
Oh, yeah.
concerned. It's horrible, and it has just destroyed me. Now I'm on antidepressants. Thank you very much. That's just been awful. So I presented her with something again. It took me a lot of time to put out there, and she doesn't really want to look at it. And I don't know if it's
Yeah.
just the ways you
And
have.
don't spend your time dealing, if she doesn't want to look at it, then no
Well,
matter
she
what
said, I
do,
told
there's
you
a-
what you could do. You could buy it without your Medicare, and then it would be like $200 more. And I'm going, wait, I have insurance. But anyway, so
Yeah.
I just know, I want to be able to find, CHADD. None of these organizations provide a list of.
Yes, they do. CHADD and ADA both have
Wait,
directories. They
wait,
have
wait,
directories of
Wait, let me
people.
finish. Okay, they
Okay,
list.
I'm sorry.
They list them. No, you're an ADHD. It's okay. That's how I ended up with a guy years ago who should be in jail. He may have gotten to jail actually, because on CHADD long time ago, I called in and got this guy who was a doctor, but that was a bad deal. It took me 30 years to come back because it was so scary. But so basically what I would like to ask is it legal? I just need to have some consistency. I need to be able to go. I've lost 3 pharmacies now. They go under. These are the independents.
Mhm.
And they're the best. But McKesson, the biggest distributor of drugs, is going around systematically and
So Sally, what's your question?
my question, thank you. We'll get there. My question is, I want to find somebody who takes Medicare, hopefully right in this area, because she's bounces back and forth to another state. If a prescriber can prescribe 2 different doses. So if 70 milligrams of Vyvanse has been sold out at this 4th pharmacy, can the prescriber put in there, if you don't have her optimal, switch her to the 60 milligrams or vice versa? Is that legal or not legal?
The prescriber can let the pharmacist know they're willing to do that, but the pharmacist can't on their own gives you 60 instead of 70 because they need a prescription that says 60.
But can the prescriber say we want 70, but if you
Yeah.
are out of it, that's not acceptable anymore. It's caused
You
great
can just say,
pain.
if I just say, please notify me it's not in stock, I can substitute and we'll send a new RX.
Well, that's why she would have to do another one, and she's not willing to
Right.
do that.
Yeah, you'd have to do
She doesn't
another
want to do
prescription.
that.
Okay, Sally, we need to go on to the next person.
He
Thank
answered it.
you.
That's good.
Yep. All right, Richard, you're next.
What? Who, me? I didn't
Sure.
raise my hand. I'm just spamming in the chat. So
Yeah, well, it's a good
Okay.
question.
it's more a philosophical thing, and it wasn't that important. But just, why does society pity autistic kids more than ADHD when the instance of autism is only 1 out of 30, whereas ADHD is 1 out of 12? Plus,
Yeah.
half of autistic children have ADHD. So why
Mhm.
can't society pity us?
My own opinion, it would be that autism is a more dramatic and visible.
Yeah.
You can tell if someone's rigid and has a hard time with change, or anxious. Anxiety is absolutely sky high in anybody on the spectrum. And ADHD is not that evident. I mean,
Yeah.
people would look at me and say, you're a doctor, you can't have ADD. Yeah, I can. And I've known and treated many doctors who do. So it's not evident, and then people can't, since you don't see anything different, and I think we all, I'll generalize, I guess, people tend to think, well, I think this way, my brain works that way, and you're a human being also, and you have a brain, so it ought to work the same way. And I'd say, well, are you wearing glasses? Take them off, read that sign. Well, squint, try harder, you're lazy.
Harder.
It's a biological difference.
Yeah.
Yep.
Yeah.
So, and I'm gonna jump to a question here if I can, Beth.
Yeah, go for it.
Melanie asked on
Yeah.
the chat about other things which you can take that would mimic the effect of stimulants. Not exactly. And if I could find it on the particular computer I have, which won't let me get to where my files are
We can
without
follow up
giving
and
seven
send it out also.
things. But the basic, I guess, biochemical glitch in the frontal lobes, where the executive functions are, and planning and organizing and all those things, is that the nerve signal, the signal doesn't get from one nerve to the 10,000 or so it's connected to. So it's not a direct wire. You have to, the signal comes down and one nerve releases dopamine in this case. And then that is kind of, there's this chemical bath that all these are in, and that bounces on receptors in all these other nerves. Great, takes the signal along. Then there's a system for recycling that, a reuptake pump, because our bodies would much rather reuse something than have to make it new. That takes energy. So it's put back in, ready for the next signal. In people with ADHD, that reuptake is going too fast. And that's the genetic part of it. And there are, I think, at least 12 different genes, but specifically one or two are the main influencers.
I have a follow-up question though, because there's two different classes of stimulants. There's the ones that help with the production, my understanding, the production of dopamine, and then there are those that inhibit the reuptake of
No,
dopamine.
there's
Oh, okay.
nothing that increases the production. So amphetamines do two things. They do slow down that reuptake, and they act like norepinephrine, another neurotransmitter, which can substitute for dopamine. They also squeeze a little bit of more dopamine out, so they don't produce it. The same amount of dopamine is in that first cell. It's just that they get more released and slow down the reuptake. The Ritalin ones, methylphenidates, just slow down the reuptake, which is probably where I guess the amphetamines are sharper. They have an edge and more jump to them, which is good for some people, not for everybody. So in a dosage, if someone's taking, for instance, a 10 milligram Adderall tablet, in order to get the same focus effect, not the same jump energy, focus, they may need 15 or 20 milligrams of a Ritalin tablet. And that's medical math, and ADHD is just weird. It's at least as complicated as calculus.
I wouldn't expect really that there's anything we could do to mimic that kind of thing, because of just the nature of how complicated it all sounds. And but I am interested in, I do notice that the effect of my medication wears off over time. So sometimes I've taken
Tolerance.
a couple days off, or wanted to look into supplements, or even just, exercise as a way, or brain training. And so that's kind of where my question was sort of geared towards.
Oh, sure.
yeah.
Okay. Yeah, there are a lot of, well, there are some non-stimulants, and the one that's been out longest that I think that's still the better one of those is Strattera was the brand name, atomoxetine. For someone who doesn't also have an underlying anxiety disorder, it works about half the time. 25% of people just doesn't work. And the other 25% have side effects that they don't want to take it anymore. People who also have underlying anxiety, it works for 70% of them. So that's doesn't, and what we're learning now as there's more experience with it, sometimes taking both of them is worth it, because the atomoxetine, if this was your kind of baseline level where your ADD function is, you want to get it up to here. Well, the atomoxetine may get it partway up, but then there's less distance for the stimulant to take it up for times you're taking a test or you have a job interview, or yes, sometimes at work you need more. Other times the atomoxetine may be enough to keep things going, and it doesn't wear off because you take it every day. There's a steady blood level of it. It's not going to wear off at night trying to have a
Right.
conversation with someone at 8 o'clock at night, but your stimulant's worn off, it doesn't go as well. And yes, there are supplements that can help. Omega-3 certainly does. Whether taking tyrosine, which is the next step or the step before dopamine, that can help make sure you have the most dopamine your system is programmed to make.
Yeah, I've
But-
taken tyrosine. It helps. I think there's even a precursor to L-tyrosine, which is PHEA, I think. I think it's called. PHEA is the precursor to L-tyrosine, which is then the precursor to
Yeah,
dopamine. Yeah,
so that those things can help, and
yeah.
for dopamine there is, then there is for the medications to act on. Anything that sure can reduce the dosage of any medicine is great. I don't
Right.
think
I
that-
noticed taking my fluvoxamine, my SSRI,
Mm-hmm.
with my stimulant. Actually, I mean, I don't know if anyone else experiences this, but it's helpful.
Yeah, I think there are a lot of, and that's where a lot of different things are going to be more helpful than just trying to take a whole lot of one. And for instance, in high blood pressure, hypertension, the average number of medications a person who has that takes in order to get good control of it is 3. If you took only one of those, you'd have to take really high dosages. Well, then you get into side effects. But if you take smaller amounts of 3 of them that work in different ways, then it controls things better. And that's where the atomoxetine works in a different way than the other stimulant ones do, so that you're getting the combination, but then you add, yep, you're taking tyrosine, take magnesium, that helps at night in terms of relaxation. It also is what's called a cofactor in biochemical reactions. So some things in converting tyrosine to dopamine, whatever number of chemical reactions there, they would work really well at 140 degrees. Well, we don't work very well at that. But if there's a cofactor of magnesium or zinc, those are the 2 more common ones, I believe, then it works better. So taking magnesium can help in a couple different ways. Exercise, definitely. For the 2 hours after exercise, you can make more brain development neurotropic factor, or some combination of those that begins with a B and it ends with an F. So then In other words, you can lay down neuron tracks better after exercise. And if anybody wants to read a great book about exercise, the science of exercise, it's called Spark, written by Dr. John Rady, who was the one along with Ned Hallowell who wrote Driven to Distraction. And Dr. Rady he's a psychiatrist in the Boston area, says, well, I'm glad you're here for an appointment. Let's go for a walk and we'll talk. And so their appointment is also going on a walk. He certainly gets a lot of exercise if he's seeing 7 patients a day going for a walk with all of them. But yeah, exercise makes a difference. The absolute most important thing, bar none, is to get 7.5 to 8 hours of sleep. You can take all the stimulants you want. You can be awake, but your memory still isn't going to work. And things don't click as well. One of the better books about sleep is called Why We Sleep by Matthew Walker, I think his name is. And it looks at exactly what goes into the physiology of sleep. All animals do it. They need to have sleep. For whatever reason, elephants only need 4 hours of sleep and giraffes need 11. And we need 8 to 9 in different amounts at different stages. So that's the key thing. That's a foundation. That's where it's during sleep that what you've learned that day turns into what you know, short-term memory into long-term memory. That happens during REM sleep. Sleep cycles are usually about 90 minutes long. Most of that happens in the last sleep cycle. If you only get 6.5 hours of sleep, you're cutting off your last REM cycle. You're missing out on putting that information into long-term storage. So I think sleep is just one of the absolute primary things that people have to do.
We're getting some questions on sleep, and can you talk about the alpha agonists? I mean, they're great for emotional regulation, but they can help with sleep as well. I didn't know that. I started taking mine right at bedtime 3 years ago, and I was surprised at the difference.
Oh yeah, guanfacine, one of the alpha agonists, and clonidine, which is in the same class of things. Yes, one of the side effects is to make you sleepy, and clonidine has been used. What's one of those things? How did someone working with kids who are 8 to 10, who are oppositional, contrary, always argumentative, decide that this old-fashioned, useless blood pressure medicine is going to help their being oppositional? I don't know, but it does. And that's where, and clonidine also makes you sleepy. So a lot of kids and adults now more and more take some clonidine at night. You get sleepy. It makes you sleepy for about 45 minutes. If you miss that window, then it's not going to work. But guanfacine, which I think is a better alpha agonist, also makes people sleepy. 50% of people have that as a significant side effect. So you take it at bedtime, take it before dinner. It can have a delayed effect on sleep sometimes. That's going to help you sleep better. And it also works a different part of the ADHD puzzle.
Can you talk about how stimulant medication, like some people can take their stimulant meds and fall right to sleep, even after they just took them. Other people, they take them earlier in the day and they can't sleep later on that night, right? I don't know enough about it, haven't read any research about why that is.
I don't know of any specific research. I know what kind of it would be called the oral tradition among people who treat folks with ADHD. We pass this along one person to another. If someone says, well, I can't fall asleep, my mind's going. Okay, I'll ask, are you anxious about something from that day or the next day? You're worried about you have to do this, or you didn't do it well? Or are you just thinking about all kinds of different things? Your pinball ADHD mind is going to here, and oh, that's kind of cool, and here. And if they say that, I'd say, you know what? I want you to take 5 milligram tablet of your stimulant meds an hour before you go to bed, because it's going to do the same thing as in the morning. It's going to calm your mind down. Now you've got 3 things you're thinking about instead of 43, and you can go to sleep. It's why some people, myself included, can have some coffee and put the cup down and take a 20-minute nap. It's just, that's the way brains work. So reducing that, what I think is a great part of ADHD, the associational mind, but reducing the pinball part of it, which can kick in at night. Okay, you're in bed, it's quiet, you don't have a lot of other stimulation going on, and you get thinking about random things. Unfortunately, one of the things that triggers all of that is you got in bed, you looked at your phone for half an hour, if you're lucky, that was only half an hour, then you put it down and you try to go to sleep. Well, your mind's still. So social distance from your phone, put it away from where you can reach it. It helps your sleep and it helps your mind relax. So yeah, that it's there, that effect on sleep, but sorting out, in a research study, I've not seen anything about it. But
It's no wonder that we end up, I mean, we go to bed in a small room, we're confined to a bed in a dark room, sensory deprivation. We're busy moving around all day long. And yet now we're expected to stay in one small area. And
I wouldn't say it's sensory deprivation. It's rest from the overstimulation of noise and social media and all kinds of different things. Glaring light. I don't know if anybody can tell, but the glasses I'm wearing have a slightly yellow tint to them because they are blue wavelength blocking glasses. I heard about them, thought, okay, I'll get some. I needed new glasses, put that on. I cannot believe how much less glare there is from the white looking at a computer screen. It's amazing. And by the end of a day of doing this all day, at 5 o'clock, my eyes were they were tired. They didn't
just like
ache. I didn't just want to keep doing it. It's much, much easier.
we
And
have somebody
actually,
who's, oh, sorry, keep going.
one of the things that can help with sleep is to wear some kind of a blue blocking lenses. It's not prescription. It can be, there are various, sometimes they look like goggles, or that look more like glasses, but wraparound. So like sunglasses that wrap around that block blue wavelength of light. Why is that important? Melatonin helps us go to sleep, and everybody makes it. People with ADD don't make it as well or as predictably. And there's a hormone, melatonin's a hormone. There's a kind of the balancing one called orexin. Blue wavelength light stimulates orexin. When orexin is going, that turns off melatonin. So if you can turn off the orexin, the blue blocking light, or have it's not enough to just say, okay, I'm gonna change my Kindle to the non-stimulating screen, your computer. It's in every single light bulb. You can get ones without blue in it, but that's not practical. So block the blue wavelength, orexin production goes down, melatonin goes up. You do that 2 hours before bed. You've got your own natural melatonin working. You don't necessarily have to take melatonin. If you do take melatonin, take it 2 hours before bedtime, not right before. And so, because it takes it a while for it to get going.
Interesting.
So that's a long answer, Melanie.
That's a good one.
Your point that, and a lot of people else, other folks on the chat, that there are many things to do for ADHD besides just take medicine. What I say is that, yeah, you have to have strategies, brain hacks, workarounds. You have to have sleep, get some exercise, avoid red food dye in things you eat, and have protein at meals so that you don't run out of energy at 4 o'clock because you didn't have much lunch, because your stimulant suppressed your appetite. So that's more in children, not so much in adults, partly because we know we have to eat. But also, if you take your stimulant every single day, your system gets a tolerance for that effect on appetite. It may take a couple months, but 3 months later, it's probably not affecting your appetite. Some of us adults wish it would affect our appetite a lot more. It doesn't. But often, and this is another one of those myths, oh, you need a drug holiday. You don't take it on weekends. So your system is more natural, whatever, your appetite's better. Yeah, but then you've not allowed that tolerance to the appetite effect to develop. So you're always going to have it if you skip days of taking. And it's not just so you can study better or so you can focus at work. Weekends, are you talking to people? Do you need to follow their conversation and not space out? Are you going to drive a car? Do you have to get some things done Saturday morning? That's what medication also is going to help with.
Like taking a holiday from your reading glasses.
Yeah. So my way of looking at it is what I've called the tripod model. You have to have the lifestyle things, the sleep, exercise, nutrition, and brain rest, and stress relief, mindfulness practice. And the second part of that is the strategies and brain hacks. And the third part of that is medication. They work together. Ideal is to have all three of them. It's not just take medicine and everything's going to be great. It's not just exercise a lot, which can certainly help with stress and yes, or attention. And Dr. Rady said, well, if you could do 10 minutes of intense exercise 6 times a day, you probably could control your ADD. And I'm thinking, great, then I'd need to take 6 showers a day. And I don't have time to do that. Because if I do 10 minutes of intense exercise, I'd have to turn my camera off because I'd be sweating all the time. So those things can help, but it takes the combination. The tolerance, and I see, Melanie, your question about in the chat about tolerance to the stimulant effect on focus. And that's true. Some people seem to have that happen more often than others. And you're right. One way to fix it is to take some days off. Another way is to, if you don't have side effects to it, switch to another type of stimulant. So basically, there are 3 chemical molecules that are stimulants: methylphenidate or Ritalin, amphetamines, which are Vyvanse and Adderall, for instance, dextroamphetamines, and Focalin, dexmethylphenidate, which is a chemical cousin of methylphenidates, but not exactly, and it's different enough that it may work where the other two don't. So say someone is taking Vyvanse, and I see over the past 3 years, well, they started out taking 40, and about a year later went up to 50, and about a year later, now they're at 60, and we can't just keep going up all the time. Okay, they could switch to Concerta. It may not be as good, but it works. And if they do that for a month, then the Vyvanse at 50 is probably going to work. It may be 60. One guy I see takes Concerta during the week because he can focus better on work. He takes Adderall on weekends because he needs to have enough focus to function, but he doesn't need the hyper dig into it that Concerta gives him. So he alternates during the week and weekend. And some people, yeah, you're stuck. You have a side effect to Ritalin or Adderall, makes people angry. One fix to that is just use a plain dextroamphetamine, Vyvanse, dextroamphetamine tablets. So there's a lot of little tweaks to make with medication, but basically get around the tolerance by taking one of the different ones. Maybe it's not ideal, but at least it's a lot better than taking nothing. And then you can switch back to the other one. Or if you find
Neat idea. Okay. Chris has a couple of questions. Trying to figure out, Chris, why don't you go ahead and come in? You'll know which ones have been answered and which ones haven't yet.
Sure, yeah. I think some of my questions have been answered already, but I'm just curious if there's a specific medication that you would not recommend for a person with ADHD, or have you found that specific medications will actually make things worse for certain people? Like, for example, I'm taking Wellbutrin for depression, and it seems like it's made my memory and focus worse. So just a general question.
Yeah.
Thanks.
And that gets to I guess that we're all unique. What's going to work for some people isn't going to work for other people. So the fact that you feel worse with Wellbutrin, bupropion, many people with ADD, it is activating. It works on the energy and drive because it works on dopamine and norepinephrine systems, not on serotonin like many of the other antidepressants, anti-anxiety meds. For some people, I think it's only been about 3 out of 3,000 people I've seen, all they need is the Wellbutrin. They're way too sensitive to even 5 milligrams of anything else. That works for them. So basically, if you take a medicine and you feel worse, you have side effects you don't want to tolerate, it doesn't matter what it does or doesn't work for someone else. For you, it doesn't. Switch to something else. And I think that's one of the things I've learned, and I really respect Dr. Thomas Brown, who's one of the 2 most expert people on ADHD. He said, what I learned about ADHD, I learned by listening to my patients. And that's what I find and realized, okay, what this person is telling me isn't on the list of side effects for this medicine. I don't care. It's what they are seeing. And they stop taking it, that particular side effect or goes away. They start taking it, it comes back. All right. That's enough proof for me. I don't have, it doesn't have to be, gee, it's not in the list. It couldn't be that. It's in the list for you. So there isn't a blanket answer in terms of ones to avoid, ones to take. I think not combining things that tend to be stimulants. Now, the Wellbutrin and a stimulant, whatever ADD medicine, for a lot of people that work fine, doesn't seem to overstimulate. For some people, it does, not necessarily a stimulant effect. So Effexor, venlafaxine, can tend to increase blood pressure. Strattera, atomoxetine for ADD, can tend to increase blood pressure. So can Wellbutrin, and so can the stimulants. Any one of them may be 3 to 5 points for most people. Some people, yeah, they're up into the, you have a blood pressure of 148 over 95. That's not good. Can you switch stimulants? That might help. But you know what? You can take a blood pressure medicine, brings your blood pressure down. So you can take a stimulant and get the focus you need, and your blood pressure is controlled.
Would guanfacine help with that?
It might, not that much. I have to say, I don't think I've seen, both in my general practice and even now, of course, I see what other medicines people are on. I've not seen guanfacine on someone's list for blood pressure if it's the 5th medicine they're taking.
Yeah, it's not an effective one anymore.
It's not very
Yeah.
effective. It doesn't hurt, certainly. I mean, it can add to the balance a little bit. The other thing about blood pressure, though, is it's 6 to 8 points lower, usually at home, than it is in a doctor's office. So treating, and finally someone did a study on that, said, okay, we're going to ask you to take your blood pressure at home. We're going to, check it anytime you're in the doctor's office. We'll compare them. The average was 6 to 8 points lower at home. So the most reliable blood pressure measurement is,
Staying away from your doctor's
yeah, first one is don't go to the doctor, or at least don't spend all your days at the doctor's office. But take your blood pressure morning and night. So if you're taking a stimulant, take it before that, take it 9 o'clock at night for 4 or 5 days in a row and average it. That is as reliable as a procedure called ambulatory blood pressure monitoring to seeing what your usual blood pressure is. Now, if you take it in the middle of the day when your ADD stimulant is operating and it's 15 points higher, then that's something to at least look at. You also smoke cigarettes, toss those first and then check your blood pressure. They're going to have way more effect than your stimulant is. But some people are very sensitive to the effect of a stimulant. Their blood pressure goes up into a higher range. And then there's always a risk benefit. Someone just really doesn't like taking medicine. Well, you have to make a choice. When you're worried about the high blood pressure, appropriate concern, then you may have to not take as much stimulant or not do it at all, or take a medication for blood pressure and you get to take your stimulant. There are at least 3 basic medications for blood pressure which have minimal side effects, can protect the kidneys, can help in a lot of ways. It's worth trying those if stimulants pop your blood pressure up too much. So, long answer to your question, there isn't a given single medicine to say, don't take that. and it amounts to, if you're having side effects, you feel worse, whatever, then time to see if something else is going to help.
Gotcha. Yeah,
Okay. Just did
thank you. Appreciate that.
last call in the chat for questions. Let's see. Where are we?
I'm want to also come up and answer a couple of the questions that Beth had passed on to me that people had passed on to her. And a number of them were about how come doctors don't take their time to listen? How come they don't seem to want to take the time to dig into this or switch medicines or whatever? There is a terrible time pressure on people in primary care, mainly pediatrics, family medicine. Got to see more people because that's how you make revenue. With large corporations buying up practices, they expect profit out of those. The only way a primary care doc can bring in more revenue is to see more patients. I can't go out and do 2 surgeries and that brings in $2,000 each to the system. I would have to see 20 more people a week over a month to do that. So docs are pressured into, you have to move fast. There's a way to do it, but more docs don't know about it, and or they're nervous. So I've got to get to the next person. And one of the, I think I'll try not to go on too long a rant here, but one of the worst thing that pressures on a doctor is there's a average number of patients per year that family doctor sees or a pediatrician. There's the Medical Group Management Association, which is mainly a bunch of big clinics. Pool their data and say, okay, this is the average of what a family physician should see per year. And most of them say, but we don't have average doctors, so that's going to be the floor. Everybody's got to see more than that. So if you're seeing under that, well, you're really seeing only the amount of patients that someone at 0.8 FTE is. You're working 1.0 in terms of hours. So we're going to only pay you 0.8, but you still have to work 1.0. That's crazy from a doctor's point of view. Okay, I've got to see more patients, which means there's less time to see any given. I'm not in medicine to make money, and I certainly haven't as far as getting more and more and more.
Sorry, who's making that decision?
The accountants, the people
Like the big medical centers, because they're the
yeah.
only ones that can
either
actually.
the big medical centers. Now I
Patient.
tried to go see my primary care nurse practitioner, and that his small practice had been purchased by Optum, one of the big into everything corporations. And so he will have to go by their rules of how many patients you see instead of working it out in your own practice. United Healthcare owns 10%, employs 10% of the physicians in the country. 10%. And all of them are held to, these are the numbers you have to produce because the accountant says so. And between accountants and attorneys, medicine's a mess. And yeah, I agree about Lauren saying socialized medicine. In Canada, yes, they have a single payer system. You can go to private payers, same thing in the UK. But Canada tells the people who make Adderall, this is what we'll pay you. If you want our business, this is what we'll pay you. Medications in Canada, same exact one, same box, everything else made by the same people, cost half as much because they can say that. On the other side, in the UK, one patient of mine who is from England and his son still lives over there, he was told through the regular National Health Service, there's a 5-year waiting list to see someone about your ADHD. 5 years. Well, that's absurd. So they went through the private system, as in the doctor works in the hospital National Health Service system in his practice, 30 hours a week, and 10 or 15 he does in his private practice. He could get seen in a couple of weeks. He had to pay for it out of pocket. It wasn't paid for the way the national health system is. Don't make Medicare for all. Whatever we do with socialized medicine, don't do it with Medicare. Either that or have someone else figuring out how to do it in there.
Yeah, that's too bad.
Yeah. So the answer in a lot of the things about doctors taking time, part of it is they don't know enough about ADD to look for it. And that's not necessarily their fault. They haven't been taught that. Or they take on a lot of the biases and prejudices. And they also are pressured to see more people. And one family doc has published his strategy for being able to evaluate someone with ADHD over 4 visits. So introductory visit about it. He says, I want you to read these things. I want you to do these various, we call them rating scales, screening scales about ADD and anxiety and depression. And then to review those and more in depth specifically about ADD questions. Do some more, patient does some more reading, brings back questions. Doc looks at analyzing some more things. You can do that over time. It doesn't have to be done in all one visit. When I was in family medicine residency, that's what we were kind of told. You're going to have the continuity of care. You're going to be able to see people over time. Most things, there's not a rush to have to make a difference. Unfortunately, someone changes jobs, they change insurance. Now they can't see that doctor. They have to see this one. Your practice gets sold. Nope. Now you have to go with a different formulary or a different doctor. No, you can't see that one. You can only see these specialists. You can't see those. That's part of the mess. I'm going to look and see if there's some other significant ones here as far as this was one, ADHD symptoms can look like other problems like anxiety or depression. How does this make providers, clinicians misunderstand it? One of it is if you don't know about it, you don't look for it, you don't see it. And anxiety, depression are real common. Family docs see people with those all the time. So I recognize that. And they don't know the fine points to ask the next question to find out, oh, you're anxious because you aren't getting things done and you're overwhelmed. Wonder if you have ADD. And I've seen a number of people, yep, I started the stimulant. I didn't need that anxiety medicine because ADD had been there ADHD had been their main issue. If you could give one piece of advice to someone newly diagnosed with ADHD, what would it be? To use only ADHD-related organizations as your initial source of information. That's ADA, CHADD, CHADD, the Canadian one. They're going to have evidence-based information. They have support groups. They have information for families, information for the patient, information for your doc. Do not use TikTok unless someone is a professional, a licensed clinician. Hopefully, in the next couple months, I will have things out on TikTok, because that's another way to reach a lot of people. And it's going to be evidence-based kinds of things, and not, oh, gee, I must have ADD because I don't get things done until the last minute and I forget stuff. So I've got ADD. As of, it was probably a year and a half ago, there had been 6.5 billion hits on TikTok on ADHD, which is huge. And unfortunately, I think more of the people on TikTok talking about ADD do not know what they're talking about. So don't use TikTok. Don't use what a friend's cousin's brother says or took or whatever. Use reliable information. That's the first advice that I'd give to someone who initially diagnoses. So, other pressing questions that people still have. Thank you, Sally. If I'm looking puzzled every once in a while, it's because I have two screens going and I can never figure out how to get the darn mouse from one to the other. So I end up, for some reason, it's if I have it at the bottom of one, it goes to the top of the other, and that drives me crazy. Yeah, TikTok averages about 75% inaccuracy. I'm not surprised.
I'm sorry to disappear. Turns out the dogs won't go outside when it's dark.
So have some outside lights.
Yeah, I know. I know. They need an escort. All right. Well, are we all run out of questions?
You'll probably run out of energy.
Yeah.
I'm sure there's.
Sitting there. I don't know if Eric is still on. Sometimes he has to drop off. He's in Florida. So
I see one question. This was from Richard. Do I
Uh-huh.
advise trying mushrooms? I don't advise it because we don't know enough about it. I know it's being looked at and studied. Thankfully, good studies in terms of post-traumatic stress syndrome, and it probably helps if it's done as a therapy-assisted trip, basically. That's different than taking the microdosing. There aren't studies that I know of, certainly that are reported. I think there's some ongoing on the microdosing. I'm not sure that it's help for specifically ADHD. I think it can help, at least preliminary things, seems like it can help with anxiety, probably depression, but I don't know that it's going to be the thing as far as focus. It may eliminate those things as a problem that gets in the way, and I'd say there just isn't enough known about it for me to say, yeah, you ought to try this or take that.
well, I think we should wrap it up. It's getting late. Yeah, I think we've got it. Well, Dr. Pomeroy, thank you so much. We'll get the follow-up list of supplements, and I tried pretty much to put in a link for everything that you mentioned, but it'll come up in the recording. And the recording will be available on our YouTube channel and on our seattlechadd.com website. And then you'll also see parts of it as Dr. Pomeroy uses it with his, who knows, you'll probably,
No,
find out.
Yeah. Stay tuned on that one.
Yeah, stay tuned. So we're excited. We're so thankful to have you here. It's nothing.
And my pleasure.
Nothing quite like having a personal consult with you. Yeah.
Happy to do so.
Okay. Thank you so much, everyone. We'll see you next time. Bye-bye.
Bye-bye.
Thanks, bye.